This video presentation and its accompanying materials are copyrighted by the American Association for Respiratory Care, AARC. Any public display, sale, copy, or distribution of the video or materials may only be undertaken with the prior written consent of the AARC. As a registered participant, you are authorized to duplicate course materials for this program for each participant viewing at your facility. This presentation and accompanying materials can be used by staff within the institution, but cannot be resold, distributed, or displayed for profit. Copyright 2018, all rights reserved. The following is a presentation of the American Association for Respiratory Care. Welcome to Current Topics in Respiratory Care. Today's topic is Pulmonary Rehabilitation, the Year in Review. Dr. Brian Carlin currently practices pulmonary critical care and sleep medicine in Western Pennsylvania. He is a past president of the MAACVPR, American Association of Cardiovascular and Pulmonary Rehabilitation, and is active within the American Thoracic Society, American College of Chest Physicians, and the AARC. He is the medical director for Lifeline Pulmonary Rehabilitation Centers in Western Pennsylvania. Dr. Carlin discloses relationships with Synovian Pharmaceuticals, Monahan Medical, Philips Respironics, Care Medical, National Lung Health Education Program, NLHEP, and National Board for Respiratory Care.
I'd like to welcome you to the presentation today on Pulmonary Rehabilitation, the Year in Review 2017. At the end of this session, I'd like you to be able to do several things. The first is to list 3 new developments in the field of pulmonary rehabilitation, to also list 2 cardiac abnormalities that patients who are undergoing pulmonary rehabilitation have, and then finally to be able to incorporate one of these research findings into your practice in pulmonary rehabilitation. I'd first like to start to talk about COPD in general. And there are several articles that came out on COPD over the last year that I think are important and will affect how you practice and how you recommend pulmonary rehabilitation to your patients and to your referring physicians and primary care providers. The first set of articles, I'll talk about COPD in general. And there are several key articles that have been published in the last year in COPD that I think will affect how you recommend your practice to the individual patient and also to the primary care provider. The first is a randomized trial of long-term oxygen for COPD for patients that have moderate desaturation. The methods or the objectives for the trial were to test whether long-term treatment with supplemental oxygen among those patients who had stable COPD and moderate resting desaturation, did it improve outcomes. The way the trial was set up and the methods were the patients had to have resting oxygen desaturation or moderate exercise-induced desaturation. They were randomized and assigned to a group on a one-to-one basis, and those who had resting oxygen desaturation were given either 24-hour oxygen. Those who had exercise-induced desaturation were given oxygen during incremental exercise and sleep. There was no supplemental oxygen group as the control group. The outcomes were simple: time to death and time to the first hospitalization. In the trial, there were 738 patients, and they looked at a time to event analysis. They looked at, and as can be seen here in the slide, and the most important part about this slide is looking at the primary outcome of either death or first hospitalization did not differ between the 2 groups. If you look at death only, that did not differ, and when factoring out the first hospitalization, you can see here at the end of the treatment period of 72 months, there was no statistically significant difference between those patients who were given oxygen and those patients who were not on supplemental oxygen. So the results were that there were no significant differences between the supplemental oxygen group or the non-supplemental oxygen group in either time to death, time to first hospitalization, or the rate of all hospitalizations. There was also no significant difference noted in quality of life, lung function, or 6-minute walk distance. So the conclusions from this trial were in patients with stable COPD and resting or exercise-induced desaturation, moderate oxygen desaturation, the prescription of long-term oxygen therapy did not result in a longer time to death or first hospitalization. And the prescription of long-term oxygen therapy did not provide sustained benefit with regards to improved quality of life, improved lung function, or improvement in 6-minute walk distance. And I think the key to this study is that we really don't know, we don't think that, at least if you're looking at time to first hospitalization or time to death, that supplemental oxygen in those patients who are not desaturated at rest does not seem to provide any benefit. And I think we need to take this into account when we're looking at patients in our rehab programs as to whether we want to continue people on that have desaturation with exercise, whether you really want to continue them on oxygen therapy for the long term. The next trial is another trial of looking at how patients walk. And I think we've all seen this in our programs, but this is the first trial in a small number of patients, but done very well, and was entitled Patients with COPD Walk with Altered Step Time and Step Width Variability as compared with healthy control subjects. The objectives were simple. They were to investigate whether alteration in gait variability are found in patients with COPD as compared with healthy controls. Do patients with COPD walk differently than do healthy control patients? The methods, they had 21 patients, most of which were men. They were average age of 63.6 years. They had an FEV1 FVC ratio of 0.52. They compared that with 20 control subjects. And how they did this, they walked the patients on a treadmill. They recorded their gait, and they recorded the timing of their gait, the width of their gait, and the variability in their gait. And they also did it at 3 walking speeds. So they did it at the patient's self-selected speed, whatever was comfortable for the patient. They then did it at 20% lower speed, and they did it at a 20% higher speed. How they monitored the patients is seen in the slide here. They monitored the patient with electrodes that were placed at the positions as noted on the slide, and they were able to look at step time, step width, and step length. In this program, in this series of diagrams, I would have you look at the upper left-hand box. In this one, looking at step time. In those patients with COPD, you can see that the step time was different at all points of whether they exercised at a lower rate, their standard rate, or at a higher rate. So the step time was slower in those patients with COPD compared to healthy controls. In looking at step width, the step width was about the same in those patients compared to controls who were walking at their own pace or at a faster pace, but when they walked at a slower pace, their step width was a little bit decreased. So they walked with a slower, if you will, or a less wide pace overall. And then finally, if you looked at step length, the step length was significantly different in those patients with COPD. So they walked with a decreased step length compared to the healthy controls. Their results were that the increased mean and step distance and step time were across all speed conditions. The narrow step width that increased with increasing speed, and that also less variability in step width with decreased standard deviation at all speed conditions. Their conclusions from this study are, yes, patients with COPD walk with increased duration of time between steps. It takes them longer to take a step, if you will. And this timing is more variable than that of control subjects. They also walk with a narrower step width in which the variability of the step widths from step to step is decreased. I think this is important when we're considering exercising our patients and looking at how their step patterns will differ when we get them on a treadmill, for example, and start exercise at a lower than their standard pace, and then watch how their step width decreases. So I think this is a very important part of what you need to look at in your patients when you're exercising them in the laboratory. The next study looks at medications and how medications affect inspiratory capacity and exercise endurance. Dennis O'Donnell and colleagues have done several of these studies looking at several different drugs, and in this case they looked at the combination of tiotropium and olodaterol on both inspiratory capacity and exercise endurance. Their objectives were to assess the effects of this combination therapy versus placebo monotherapy on inspiratory capacity and exercise endurance time in patients with moderate to severe COPD. They actually took patients, and it was a 6-week randomized, double-blind, placebo-controlled trial. They had 5 treatment, 4 period. It was an incomplete crossover phase 3 study. The outcomes they looked at were incremental work rate psychoergometry test, and then they had a training work-related exercise test compared to a baseline test. They studied 5 different types of therapies, if you will. They looked at a combination of tiotropium and olodaterol at the doses you can see on the slide. Tiotropium and olodaterol at a higher dose than is currently available in the United States. They looked at tiotropium only, they looked at olodaterol only, and they looked at placebo. They all used a Respimat inhaler device. And in the patients, these were mostly men, 71% men out of the 586 people in the study. Their FEV1 was in the moderate severity range of 58% of predicted. When they looked at the different effects on inspiratory capacity and exercise endurance, and you can see that in this slide, that there were statistically significant changes when the combination was compared to each of the monotherapy or the placebo components, as you can see here in this slide, compared with the baseline. That are all statistically significant improvements in inspiratory capacity. The effects of exercise endurance were also shown to be statistically significant and can be seen on this slide. The placebo is the bottom line, the combination therapy is the top line, and you can see that at all of the time periods, or even at the ISO time, there was a statistically significant improvement in exercise endurance when you use the combination drug versus each of the individual drugs or versus placebo. Shown in another way, you can see that in this slide, in this case where the combinations are the two right-hand slides, or the two right-hand bars, and show statistically significant improvement in exercise endurance time over that time frame. The conclusions from their study is once daily, tiotropium olodaterol yielded improvements in lung hyperinflation by improving inspiratory capacity versus placebo, and they also had a statistically significant improvement versus monotherapy in exercise endurance time. And I think this stresses the point that we want to make sure that our patients in rehab are using the appropriate medications, because these medications, several other medications before, particularly tiotropium, has been shown to improve exercise endurance time. So you want to make certain your patients are in a good combination of inhaled bronchodilator therapy prior to their entry into the rehab program. Well, let's talk about pulmonary rehab in general. Pulmonary rehab in general, there are several studies out this year that look at this in general. And the first study that I think is a very important study was looking at the outcomes in COPD being independent of disease burden. In other words, how do our patients do that have more mild disease or more severe disease in regards to pulmonary rehabilitation? The group at the University of Alabama looked at this and tested whether pulmonary rehabilitation benefited patients with COPD independent of baseline exercise capacity, dyspnea level, or lung function. They looked at their patients over over a 15-year course. It was a retrospective study. Then they broke the patient out into quartiles based upon their shortness of breath scale score, or their dyspnea scores measured by the UCSD shortness of breath questionnaire. They looked at their FEV1, and they looked at their 6-minute walk distance. The methods of the study and the primary outcome measure was a change in quality of life as measured by the SF-36 scale, and the secondary outcome measures were change in dyspnea, 6-minute walk distance, or depression scores. They studied 229 patients. Average age was 66.5 years, 60% were men, 18% were African Americans. Their FEV1 was in the severe range of 46% of predicted. They looked at clinically significant improvements, and as they broke these patients down into quartiles, and I'll show you the results in a few minutes, and they looked at the clinically significant improvements, and they found significant improvements in most of the components of the SF-36 scale, whether it be emotional role, physical function, health perception, depression, vitality, but they found improvements in each of the components of the SF-36 scale. They didn't show any difference in the SF-36 scale across the quartiles. So those patients that had less shortness of breath did not show any difference, and it did not matter with either the 6-minute walk distance or the FEV1. And these next series of slides are looking at, this is the change in the 6-minute walk distance, and you can see here that no matter what quartile you were in, where the blue being the least severe disease patients, the red being the most severe disease patients, that all patients had an improvement in their 6-minute walk distance. If you looked at the shortness of breath questionnaire, again, there were no statistically significant differences except in the group, in the second set of series there, that you look at all the different colored bars, everyone had an improvement with less shortness of breath as measured by the questionnaire. And then in looking at the baseline dyspnea index, everybody had an improvement. there was not statistically significant changes between the groups, other than to say that people that with more mild disease also showed improvement. Their conclusion was that pulmonary rehabilitation results in significant improvement in quality of life, dyspnea, and functional capacity independent of disease burden. And where I think this is important, how you can use this in your program, is you can stress this to your patients and certainly your referring care providers that pulmonary rehabilitation helps patients even in those groups who are not that severely ill or don't have a severe disease burden. We know that it helps very well in people that have moderate or severe or very severe COPD. There has been debate, does it help people that are not as short of breath? And it does help people that are not as short of breath. Another question comes up is what happens once the patient graduates from their pulmonary rehabilitation program? Should they be in maintenance program or should they not be in a maintenance program? Rosa Guell looked at this in long-term maintenance pulmonary rehabilitation program for patients with COPD. Their objectives were to assess whether a long-term 3-year program benefited patients and preserved the short-term effects and outcomes in patients with COPD. The long-term maintenance program was set up as a multi-center prospective randomized trial that involved 143 patients with moderate to severe COPD. They underwent an 8-week rehabilitation program, which would be the acute phase, if you will, how you would call it. They underwent maintenance therapy. Then they looked at different outcomes in the BOAT index, the 6-minute walk distance, and health-related quality of life. Of those patients that underwent the maintenance program, this was a recommended maintenance program that the patients did, either came to the lab or did at home, showed that 138 of the patients completed the 8-week program and all outcomes improved, similar to what we've seen in pulmonary rehab data for the last 30 years. During follow-up, they showed that the adherence rate at 3 years was very good in the interventional group. 66% of those people followed it. In the control group, and the control group was just after the initial phase was done, they were allowed to do whatever they wanted to do without any formal maintenance therapy. The adherence rate in that group was only 17% for keeping up with the rehab program. What they showed, and this is the BOAT index, and you can see here the maintenance group is the solid lines. The dotted lines are the usual care or the control group, and you can see here that the BOAT index decreased at the 2-year period, but by the 3-year period the BOAT index was about the same. So patients were better at 2 years, and there was a fall off in the BOAT index, more so or an improvement in the BOAT index in the group, interestingly, that had undergone the control therapy versus the non-control therapy. The group in the 6-minute walk distance, you can see here the 6-minute walk distance improved. Again, the solid bars, it showed the 6-minute walk distance improved at the 1-year level, was statistically significantly improved at the 2-year level, but started to wane back towards the baseline at the 3-year level. Again, their conclusion was that there is a 2-year beneficial effect of pulmonary rehabilitation on the BOAT index and on the 6-minute walk distance for those patients who undergo maintenance therapy, but that effect vanished after the 2nd year and was back almost to their baseline at the end of the 3rd year. How does this affect us? Well, I think that maintenance programs are effective. We know that COPD is a lifelong, debilitating disease that can be and often is progressive, and that we still have to keep making inroads in patients with maintenance therapy after the initial therapy to provide the very best care we can for the individual patient. Well, what about the magnitude of exercise capacity and quality of life improvement following repeat pulmonary rehab? If somebody's had pulmonary rehab before, do they benefit from it again? This is not maintenance therapy. This is patients who underwent rehab and then followed up with a program later on in their life. They wanted to review the effects of repeating a pulmonary rehab program in a physician-referred cohort of patients with COPD, not randomized, not controlled. These were patients that completed a COPD program already, or pulmonary rehab program already, and were referred back by their care provider for a second program. You can see here that the patients had to either complete pulmonary rehab twice. Some people completed it 3 times over a 12-year period. They used a Lick's linear effects model to quantify the change based on 6-minute walk distance. Health-related quality of life is measured by the SGRQ, and then the depression is measured by the HAD scale score. You can see here that in the SGRQ, the effects after the post-second rehab program, that there was an improvement, after the first program, in this group after the second program, and then also after the third program. The first two programs statistically significant, the third program not so much. In the hospital anxiety and depression scale scores, looking at depression and anxiety, again after the pulmonary rehab program 1, statistically significant improvement by reducing anxiety and dyspnea. After program 2, again a statistically significant difference. After the third rehab program, there was not a statistically significant difference. And then finally, in the 6-minute walk distance, you can see that there was an improvement in the 6-minute walk distance, interestingly, in all 3 stages, where after the first program, after the repeat program, and after really the program 3, which would be the second repeat program. If you like to look at the numbers out there, the numbers are shown in this slide, and you can see that there was a difference in the effect of the interval between these programs. Did that make a difference? And it did not look like it made a difference of when the interval was. So if the interval was 2 years or 5 years or 8 years, the same improvements occurred throughout the course of the study. The results were that overall 6-minute walk distance improved following each pulmonary rehab program. The mean SGRQ related to health-related quality of life decreased after programs 1 and 2, but not 3. And similarly, the HADS decreased after pulmonary rehab 1 and 2, but not 3. Their conclusions were that there are clear benefits noted for a physician-referred patients following a repeat pulmonary rehab program that doesn't appear to be affected by the interval between the programs. It's the functional exercise capacity improved after each time, so patients get better after each time. And their health-related quality of life improved after the first 2 programs. I think this gives us more impetus, or should give us more impetus, to make sure that patients continue to follow the tenets of rehab once they leave the program, and then also they may need a second program down the line. This can often be done, certainly in Medicare. If you are looking at Medicare supplementation or reimbursement for this, this can be done up to a 72 session limit over the patient's lifetime. And you would have to take that into account when you're enrolling people in the United States, at least for pulmonary rehabilitation. Questions always come up about where to do pulmonary rehabilitation. Can you do it? We often do it in a hospital-based center, but can you do it in a community? And is it safe to do in the community? Looking at the people from Australia have looked at this and looked at community-based pulmonary rehabilitation in a non-healthcare facility is feasible and effective, and published in the Journal of Chronic Respiratory Disease of this year. They wanted to look at the feasibility and outcomes of community-based pulmonary rehab in non-healthcare facilities. It's probably the first study that's done looking at this, even though I know a lot of us do that in this country today. This was the first study that really looked at this. They looked at twice-weekly rehab for 8 weeks. They were prescribed regular home exercise. There was informal education. It was more of a focus on self-management skills, which I think is a very, very important part of what we do in the rehab community. They standardized the exercise training, meaning they wanted to do lower limb training for 20 to 30 minutes at a session, upper limb circuit endurance training, and lower limb strengthening. They also had a safety checklist that the patients completed, and they looked at the outcome measures of the 6-minute walk distance or the chronic respiratory questionnaire, another health-related, COPD-related quality of life questionnaire. They looked at 394 patients that were referred in, 251 attended the pre-assessment, and 163 completed the community-based rehab program. Most had COPD, not all, but 80% had COPD, and there was a greater number of non-completers, and those people had more severe disease. What they found in those patients that there were no major adverse events. 10 had irregular heart rhythms, and 4 had oxygen desaturation noted during their 6-minute walk distance test. So the adverse events, one of the outcome measures, was very few in this patient population. They also looked at the total number of admissions was lower in those patients who completed the post-rehab program, which hopefully you would expect. I think this gives us more credence to looking at rehab as part of readmission reduction programs. Total number of hospital days was less, 555 before rehab, 156 after rehab, and the number of hospital days per year per participant went from 4.1 to 1.1. They also looked at other parameters, looking at functional exercise capacity and health-related quality of life, and you can see here that the 6-minute walk distance improved above the meaningfully clinically significant difference, which is 25 meters. These improved by 44 meters, and that their health-related quality of life improved in almost all, if not all, of the domains of the CRQ questionnaire. Their conclusion was that pulmonary rehab can be done safely, feasibly, and effectively when conducted with clear guidelines in non-healthcare related facilities. I think a lot of us do this in this country right now, and in fact, even though we are in many programs are in healthcare facilities, they're separate from the mainstay of the hospital per se. I know in our programs in the Pittsburgh area, we go and we do most of our rehab. They're all done in outpatient settings, far away from a healthcare facility, several miles in some instances from a tertiary care or a hospital setting. But they can be done safely, and I credit the authors on this study for looking at this to show that it can be done safely in those type of settings as well. What about using some newer measures? What can we do with, for example, telehealth and tele-rehab? This group looked at home-based maintenance tele-rehab for reducing the risk of acute exacerbations of COPD, hospitalizations, and emergency department visits. Their objective was to determine whether home-based maintenance tele-rehab will be as effective as hospital-based maintenance programs and superior to usual care in reducing the risk of one of those three components, either an exacerbation, a hospitalization, or an emergency department visit. Their methods were all patients completed a 2-month standard pulmonary rehab program, and then they randomized them over the 2 years between 2013 and 2015 to either 12 months of home-based tele-rehab, 12 months of hospital-based outpatient rehab, similar to what most of us do today, and then 12 months of usual care, meaning after their rehab program, they let the patients do what they wanted to do with no formal rehab training. The home-based tele-rehab and what they were able to find, and this was done through a component of phone calls, from feedback from the patients through a tele-monitoring system. They looked at the independent predictors for lower risk of acute COPD exacerbations. In the tele-rehab was a ratio of 0.517. In the home-based patients, they looked at a ratio of 0.635. Similar changes were noted in the hospitalization. So the hospitalizations in the tele-rehab where their risk ratio was 0.189 compared to the regular program of 0.375. The results were the only tele-rehab was the independent predictor of ED visits, and that it wasn't a clear difference that when their conclusions were that tele-rehab is equally effective as hospital-based outpatient maintenance program in reducing the risk for acute COPD exacerbation and hospitalizations, but the tele-rehab group encountered a lower risk for ED visits. And I think this is one of the first of many studies we're going to see, and why I brought this in here is that we're going to see much more in the way, on the mode of tele-rehab, and we really need to find out how to do it best, and certainly in which patients to do it upon. But I think we're going to see more and more of tele-rehab certainly in the future. Well, some other things to look at, and some of the interests of mine are looking at heart disease and sleep. This study was just published several months ago, and they wanted to look at what are the echocardiographic abnormalities and their impact on health status in patients with COPD who are referred for pulmonary rehab. They wanted to investigate echocardiographic abnormalities and their impact on health status in a large cohort of patients with COPD referred for pulmonary rehab. They looked at a cross-sectional observational analysis. These patients had inpatient assessment for rehab, for entry into rehab. They also had an echocardiogram done in all patients, and their outcomes where they looked at the results of the echocardiogram versus the CAT score, the COPD assessment test score, the clinical COPD questionnaire, and the St. George's Respiratory Questionnaire. They wanted to look at the interaction from these. What they found in 514 patients, about equal men, equal women, FEV1s were in the severe range of 48% are predicted, that those that had one or more echo abnormalities was in over half the patients. 276 patients had a definitive echocardiographic abnormality. Now, the more important thing is that they found that 64% of those did not have any documentation on their medical record or known echocardiographic abnormality. The results that they showed, 31% have left ventricular hypertrophy, 20% had an increased right ventricular systolic pressure elevation, and 17% had an impaired left ventricular ejection fraction. The echocardiographic abnormalities, as might be expected, those that had echocardiographic abnormalities had a worse health status as measured by the SGRQ that was significant, and that there was no difference between the clinical COPD questionnaire nor the CAT score between the groups. Their conclusions were that more than 50% of patients referred to pulmonary rehabilitation had echo abnormalities, and 2/3 of these patients did not have such abnormalities recorded in their medical history. We don't know what the impact, they did not know what the impact of echocardiographic abnormalities was on health status, but I think the important aspect here, and what I think is very important about this study that we often miss, is patients with COPD often have heart disease as well that is not picked up. It's very rare, at least at the hospitals where I go, for a patient with COPD not to have had an echo at some point in time during one of their hospital stays or their outpatient. But I think when patients are referred to rehab, you need to really consider that that patient may have underlying cardiac disease and investigate that up front before starting them in the program. Another aspect is, well, how do our patients sleep with COPD? There's been several studies out there, but does poor sleep impact daytime physical activity? I think it does. It certainly does in all of you out there. If you sleep poorly at night, you're going to want to do less the next day. But they investigated this in nocturnal actigraphic sleep measures in patients with COPD and their effects on daytime performance or daytime activity. Their objectives were to provide insight into the relationship between actigraphic abnormalities and disease severity when regards to exercise level, gender, and days or parts of the week. They also wanted to look at the measures of they wanted to look at the measure of actigraphic abnormalities related to physical activity. They showed that in there, and the data analysis was quite large in this. If you know anything about the sleep world and actigraphy, there's a lot of motion that was being measured, and they want to look at, this was a general measure of motion. I'll go into that in a few moments. They monitored people with sleep and physical activity, sleep at nighttime, physical activity in the daytime with activity monitors. They looked at them for about 6 days, and they had multisensor activity monitors in place. So they had activity monitors that measured, their position, whether they were moving or not moving, and how much they were moving. They looked at over 900 people, 66% were men. They had moderate COPD, and they had moderate to severe COPD. The sleep measures that they looked at were ones of non-fragmented sleep. In other words, how long does a patient sleep before being woken up? They looked at sleeping bouts greater than 225 minutes. So did they sleep for over almost 4 hours? They looked at sleep efficiency, meaning the time that they're in bed where they're not moving or they're felt to be sleeping by actigraphy, of being greater than 91%. And then they looked at what we call the wake after sleep time, or the WASO, the time spent awake after sleep, of less than 57 minutes. Those are all good. Those are all indicators, if you have all of those in place, that all of those are indicators of a quality night's sleep, if you will. So they looked at all these, and they showed that the actigraphic estimates of sleep impairment were greater in patients that had more significant airflow limitation. I didn't throw the numbers in here, but those patients that had more severe disease had more actigraphic abnormalities, and they also had worse exertional dyspnea, which kind of makes sense. People with more severe disease don't seem to sleep as well. And they found that patients with better sleep measures spent significantly more time in the light, out in the daylight, and they spent significantly more time in moderate to vigorous physical activity. So people who sleep well do more. I think we often don't look at that in our patients, but I think we really need to start looking at their sleep quality and that's their conclusion were that there was a relationship between the measures of sleep in patients who had COPD and the amount of activity they undertake during the waking day. If we can get our patients to sleep better at nighttime, potentially we can get them to do more physical activity in the daytime. And that's the hope, and not proven in this study. This study just showed that there's a relationship between not sleeping well and poor physical activity the following day. Well, so far I've talked about primarily COPD and how the new research in the area. There hasn't been a lot of new research in other areas such as lung cancer, interstitial disease, or bronchiectasis, but there certainly is data, as you'll see in a few moments, that come out of the new guidelines where they recommend pulmonary rehabilitation for patients with those diseases. One of the best papers that I've seen over the last year is how do we actually do rehab for people that have, for example, interstitial lung disease. It's a question that always comes up. We know our patients with interstitial lung disease have certainly a very different disease process than those patients who have COPD. And how do we really evaluate and how should we exercise these people? Well, our colleagues in Australia looked at this and looked at the best evidence that's available, put it together, and published this in the Therapeutic Advances in Respiratory Disease just several months ago. We all know that the exercise limitation from interstitial lung disease is really one of 4 different types of processes, or can be one of 4 different types of processes. The first one is gas exchange is impaired because of the interstitial fibrosis that is often accompanying people with interstitial lung disease. The impairment in the pulmonary circulation. So as people develop more and more severe ILD, their pulmonary circulation becomes impaired. Ventilatory muscle dysfunction doesn't often occur in people that have ILD, but certainly can occur. And then the muscle dysfunction that occurs in most of our patients that have any type of chronic lung disease, particularly ILD. That's variable because not everybody with ILD will develop muscular dysfunction, but when we add the different disease treatments such as steroids that we often give people with ILD, that can really promote the muscle dysfunction that occurs. There's a lot of evidence for benefit out there. And in looking at their paper, we really show evidence for benefit in increasing exercise capacity, reducing dyspnea, and improving health or quality of life, very similar to what we see in patients that have COPD. There's only really 4 studies out there that looked at this, and there's no long-term data available. However, what they look at and what they recommend in the paper is the appropriate patient selection and timing. When do you initiate therapy? I think the important thing and what they were gleaning on in their paper is you want to initiate therapy prior to the time that the patient gets severely ill, maybe at the time that the patient is diagnosed with ILD. And most patients who are diagnosed with ILD have symptoms of shortness of breath and exercise intolerance. So it's very prudent to start rehab early on in the disease course. The length of the training period should be similar to that with COPD. I would just pick out an 18 to 36 program or session and then proceed in that fashion and then evaluate the patient in an ongoing manner. The duration of the benefits are really unknown, but what we do know is that the duration of benefits will outlast the program itself and should continue on beyond the program, very similar to the maintenance therapy that's given for patients who have COPD. The program components are similar again. There's really no difference. You don't have to have special equipment or do anything special or different in patients who have ILD. You want to train them on endurance training, on a treadmill or on a cycle to do more at a faster pace or at a higher level of exercise. You want to have them do resistance training. You want to also have them do, very importantly, flexibility and stretching training. Again, I don't think we do that in many programs, but we're starting to in this country. And then you also want to tailor their non-exercise training a little bit differently than you do with COPD. You want them to have education on certainly what disease process they have. And there are a lot of different subcategories of interstitial lung disease that patients may have. You want to give them a little bit different type of psychological support. And you also want to give them different nutritional support and symptom control. For example, people with ILD will often be very, very short of breath, and they often present to the physician late in the course. So these people are often very, very debilitated, and the time from the presentation to the time of their death may be very short. So you want to get them ready for that whole process, getting them better certainly, but also preparing them for the end of life issues that will ultimately come in that patient population. There's very special considerations out there, and the primary one is oxygen therapy. This is not like the very first study I talked about with a long-term oxygen trial on people who desaturate that have COPD. In those patients, it wasn't shown to benefit people either with time to first hospitalization or time to death. People with interstitial lung disease, have a little bit more leeway in prescribing oxygen for those people who desaturate, because what happens when they exercise, because of the abnormalities in the pulmonary vasculature and the interstitium, they desaturate very quickly. We often see people in our laboratory or in our pulmonary rehab program that start with a normal oxygen saturation, and within 1 or 2 minutes they're saturating in the low 80s or high 70s because as they exercise they can't reoxygenate their venous blood as quickly as somebody that either has healthy lungs or patients that have emphysema. You want to supplement them as best you can, and you want to exercise them at as high a level as they can. In fact, sometimes I will let them desaturate into the low 80s when they're exercising because I can't give them enough supplemental oxygen to prevent that desaturation from occurring. A lot different process than we do with our patients that have COPD. In some instances, you may want to use interval training, meaning that you will have the patient exercise to the highest level they can, even if it's only for 30 seconds or a minute, allow them to rest for 5 or 10 minutes, and then do that again. We do that in some of our patients with severe COPD, but again, it depends on the patient's tolerance to exercise, and just because they desaturate and can only exercise for 30 seconds doesn't mean that you stop there. You should have them wait for several minutes, allow them to reoxygenate their bloodstream, and then go back and do that same exercise again. And then what you want to do is extend those periods out 30. If it's 30 seconds now, it'll be a minute the next time, be 2 minutes, and try and get that patient up to maybe a 20 or 30-minute exercise program at one setting. You want to look at musculoskeletal disorders. Again, I mentioned many people are on steroids that have interstitial lung disease, so you want to make certain that they are in as tip-top muscular strength-wise, and that comes from the strength and resistance training that you want to do in your programs. And then there's not much data on rehab following an exacerbation, but I would certainly follow the recommendations that we start rehab at an earlier stage following an exacerbation and not wait until the patient is back to their baseline. That's the old-fashioned way of doing things. There's only been one study in COPD that showed that early exercise training did not help people in pulmonary rehab, but there's several studies, and there's a recent Cochrane meta-analysis that looks at the impact of starting rehab early after an exacerbation, showing an improvement that people that have COPD. And I suspect that we'll find that once the research comes out in the next decade, that people with ILD often have an improved health-related quality of life if exercise and rehab is started soon after their exacerbation. What types of outcomes do you want to look at? The outcomes are basically the same, and they're recommending that you want to look at the 6-minute walk distance. You want to look at exercise capacity. Some people will look at full cardiopulmonary exercise testing. We don't do that in our laboratory, but some laboratories do that, and I think that's a very prudent and proper way to evaluate someone if you have the metabolic cart to allow you to measure the expired gases and do a CPET. Health-related quality of life, I would still look at even though the UCSD shortness of breath questionnaire was designed for people with COPD, I think that can certainly be used for patients with interstitial lung disease. You don't want to forget about the anxiety and depression. I think it's another good outcome measure using either the HAD scale or the CESD scale that are very good. And then there are now been developed interstitial lung disease specific health-related quality of life questionnaires. And many of you may not know of these, but there are ones out there that the SGRQ, for example, has an IPF version. And then finally, there is the King's Brief ILD questionnaire. So a little bit different management. The process should be the same with exercise, education, psychosocial support, looking at the various outcomes that are there. And the only thing that I would do differently in those patients that have ILD is be more attuned to their oxygen desaturation, and then also use one of these health-related quality of life scales that are specific for patients that have ILD. And I think you'll see that your patients with ILD are going to have an improvement in their overall outcomes once you institute rehab in the same process that you do for a patient that has COPD. Over the last year, there have been several guidelines that have been published, and I'll talk about two of these as we conclude this hour's talk. The most recent guidelines were published out of Australia and New Zealand and just published several weeks ago, if you will. They looked at these, and I'm not going to highlight here what is all their guidelines because I think they have about 30 different guideline recommendations in their guidelines. They did this in a standardized way of looking at the literature, and really what I'm going to focus on here in the next couple slides is what are the differences between these guidelines and our current guidelines that date back to 2007. Well, the first thing they recommended is that patients with mild to severe COPD should undergo rehab. You say, well, how's that different? How's it different? Well, it's different because we're now recommending patients with mild disease can benefit from pulmonary rehab. They also recommended, based upon several of the studies, and I mentioned one of the studies before, that pulmonary rehab could be offered in hospital gyms, community centers, or at home. There's not a standardized way there's not a standard way to get people into a rehab center, for example, to do all the rehab in that inpatient facility or outpatient facility. And then pulmonary rehab could also be provided irrespective of the availability of a structured educational program. This is interesting. This is not what we do in most of our centers right now, where we have actually a structured educational program, but there is data out there that giving patients information, not in a structured way, but giving patients information can benefit those patients and can and should be used in some situations. It should be offered to patients with other diseases, bronchiectasis, interstitial lung disease, and pulmonary hypertension. That's been recommended in several of the other studies, but not as strongly recommended as it is in the current New Zealand, Australia guidelines. They weren't, however, able to make recommendations based upon the literature on what should be the duration of the program beyond 8 weeks. What is an optimal model for maintenance? We all do maintenance a little bit differently, but what's the optimal model? We really don't know. We need more research in the area. As you saw from the previous study, the maintenance program that Rosa Guell and her colleagues had done worked up to 2 years, but what about after 2 years? Can we do anything after that 2-year period that's going to extend the benefits of pulmonary rehab to patients lifelong? And then finally, they could not make any recommendations regarding the use of supplemental oxygen during exercise training. Some people do this. We do not do that in our centers. Some people will do this, but there's really no recommendation that can be done, that can be made regarding that. Probably the most important guideline that came out within the last year is the GOLD initiative, or the Global Initiative for Chronic Obstructive Lung Disease, and their recommendations. Many of you have seen these recommendations in talks, and I won't belabor it here other than to say that the GOLD now recommends that you do spirometry to prove that somebody has COPD, and then you categorize the patient separately from that GOLD classification, that initial spirometry classification, into how severe their disease is. You can see here on this slide that on the x-axis you look at symptoms, whether you look at the MMRC scale or the CAT scale, and then on the y-axis you want to look at number of exacerbations. So how severe is someone? So for example, someone in Group A, they have mild COPD, they don't have many symptoms, and they've not had an exacerbation, compared to someone in Group D who has a lot of symptoms and who has had a lot of exacerbations. More importantly, what they recommend in regards to rehab, and this is consistent with their previous guidelines that date back to 2011 and even guidelines before that, that it should be considered as part of the integrated patient management program in patients with chronic lung disease, in this case chronic obstructive pulmonary disease, who have symptoms. They also recommend that supervised exercise training twice weekly for 6 to 8 weeks is recommended. That can be endurance or interval training. It can be resistance and strength training. It should include both of those. And it should include upper and lower limb training. Whether you use walking, whether you use treadmill, whether you use a psychoergometer, you should use one of those forms of therapy. The other thing that they recommend is flexibility. I don't think many of us look at this in our patients, but look at flexibility and improvement of flexibility in our patients with COPD. And then also some of the other therapies, inspiratory muscle training, and then the neuromuscular electrical stimulation some people are using for patients who are severely debilitated that cannot simply do the exercise we want them to do. Their other recommendation, it's appropriate for most patients with COPD, not everybody. If somebody has mild COPD and no symptoms, that patient should not be entered into a program. However, it's appropriate for most patients with COPD. And what I tell my primary care colleagues is that any patient with COPD who has symptoms or exercise limitations should be considered for a pulmonary rehab program. It can be conducted in a range of places. It can be conducted inpatient, it can be conducted outpatient, and it can be conducted in the home setting, or if you will, a storefront setting away from the hospital campus itself. And they also mentioned in there that it ranks as one of the most cost-effective treatment strategies for patients with COPD, with an estimated quality of adjusted life year of 2,000 to 8,000 pounds, compared to some of our pharmacologic therapies that are at a cost of 15,000 or more pounds over the quality of adjusted life year.